Thank you, Beth, and thank you to Dr. Kinney and Dr. Sharma for having me here today. My name is Alina Enache, and I'm a nurse in the cath lab at Mount Sinai Hospital. First, I also want to say thank you for your patience. I know it's the end of the day. Everybody wants to get home, so I'm going to try to keep this short. And I will talk to you today about safety handoff and transitions of care. I have no relevant financial relationships. So a little background. While it sounds simple, a high quality handoff can be complex. Failed handoffs have been a long-standing and common problem in healthcare, and that can be dangerous. So although adverse events can occur anytime during hospitalization, handoff communication is often the cause of some of these avoidable events. One of the issues found with inadequate handoff was lack of standardization. So in 2006, the Joint Commission established a national patient safety goal that addresses handoff communication. The goal was to implement a standardized approach to handoff, including the opportunity to ask and respond to questions. In 2010, this requirement became standard practice, which is great because high-quality handoff improves patient outcomes and patient experience. So what is handoff? Handoff is a transfer and acceptance of patient care responsibility achieved through effective communication. It is a real-time process of patient-specific information being passed on from one caregiver to another or from one team of caregivers to another. And the purpose of this is to ensure the continuity and safety of patients' care. At Mount Sinai, in the cath lab, we implement bedside handoff to allow patients and families to be involved in the conversation. This allows for the opportunity for patients and their family members to ask questions about their plan of care. So we talked about a standard approach being key when it comes to high-quality handoff. I'm sure everyone here is familiar with SBAR, which stands for Situation, Background, Assessment, Recommendation, and modified to include response, which, like I said, allows the opportunity to ask questions and also address the plan of care going forward. It's a technique used to facilitate and prompt appropriate communication. So how do we give handoff in Mount Sinai at the cath lab? Again, standardization is key. So on this slide, I've included the report form that we use in the cath lab. As you can see, I filled it out with some basic information, and there is no real patient information on this slide. This form follows the patient from the time they arrive in the cath lab to the time, either from home for their scheduled procedure, from the emergency department, an inpatient unit, or outside hospital transfer, to the time that they are either discharged home or admitted to an inpatient unit. The form is filled out by each nurse taking care of the patient in each area of the lab. Bedside handoff is then given off of this form. Because we are a procedural area, we focus more on the procedure done as well as the diagnosis found during the procedure and what intervention was done, if any. We also include access site and closure device. And finally, we include what the post-procedure plan and disposition for the patient is. And again, this form is not a part of the medical record. So where do we hand off to? We have a few different areas. First, the post-cath recovery area, which is in our cath lab. When we keep our patients in the recovery area post-procedure, we give bedside handoff to the nurse assigned there using the form I mentioned in my previous slide. If our patients are being admitted, we give verbal telephone report to the nurse on that specific unit using the form I mentioned as a guide for our report. And of course, we allow the opportunity for the receiving nurse to ask any questions. If our patient had a PCI done, then they will be accompanied by a nurse during the transport to the unit, and a second brief handoff will be done at the bedside with the receiving nurse. So this allows both nurses to assess the access site, any IV drips the patient may be on, and again, ask any questions they may have. Next, I will talk to you about transitions of care. Transitions of care refers to the movement of a patient from one setting of care to another. This includes from hospital to ambulatory primary care practices and specialty care practices. So this means patients that are discharged home to follow up with their PCPs or cardiologists. Other examples include long-term care facilities, home health care, or rehab facilities. In our case, in the cath lab, we generally discharge our patients home with follow-up. Those more complex patients needing long-term care are usually admitted and discharged from there. So this is important because safe and effective transfer of responsibility for a patient's medical care relies on effective provider communication with patient and their comprehension of discharge instructions. So like I said, some of our patients are discharged directly from our post-cath recovery area in the cath lab. These are patients who've had diagnostic procedures without intervention, and they're usually sent home in 2 hours. We also discharge our post-PCI patients that are deemed appropriate by the MDs for same-day discharge. These patients are usually kept for 4 hours, after which post-PCI labs will be drawn, and if within normal limits, they will be discharged home. Throughout this whole process, constant communication with the RNs constant communications with the RNs, the MDs, and the NPs is important, as well as with patients and their family members to keep everyone updated on the plan of care. We also address any discharge challenges such as transportation, and we have social work involved to assist with transport. As Jeannie mentioned, patients receive detailed discharge instructions that are both verbal and written. They're educated regarding post-PCI activity and any restrictions. Emphasis is placed on new medications. Follow-up care with their cardiologist is also emphasized. And again, patients and their family members are involved in the discharge instructions and encouraged to ask questions. The nurse who is doing the discharge teaching, they make sure that both patients and their families verbalize understanding of these instructions. All of our patients are also educated on and referred to cardiac rehab. Cardiac rehab is an evidence-based secondary prevention program designed to improve cardiovascular health in patients who have suffered from a cardiac-related event, procedure, or surgery. So that includes majority of our patients. Transitions of care doesn't just stop at discharge in Mount Sinai Hospital. We have a program called the Transitions of Care Center, or TOCC, which is a centralized nursing discharge telehealth center for the Mount Sinai Health System. TOCC RNs provide targeted phone calls to patients discharged from the Mount Sinai Health System hospital sites within 24 to 72 hours. TOCC collaborates with many interdisciplinary providers from both the inpatient clinical teams and ambulatory settings. They use a standardized script to ensure that all topics are covered, and they provide education regarding disease management, medications, diet, and activity. They also assist patients to coordinate any follow-up appointments, as well as offer assistance with referral programs, such as the cardiac rehab that I mentioned. Mount Sinai also has a specialty program called AMI TOC, which started in November 2020 and has a dedicated NP and RN. They ensure that patients who have had a heart attack will receive bedside education prior to discharge, and that patients will get their medications and are compliant with follow-up appointments, which should be done within 2 weeks to prevent readmission. Readmission rates have gone down since this program started. So in conclusion, effective handoff communication improves patient outcomes and patient experience, and transitions of care ensures health care continuity and promotes patient safety. Thank you.